Good morning. Today I will tell you something about the problems that can happen to the eyes because of the chemical injuries. All of you may be knowing that the chemicals can produce major problems to the eye if not treated properly. As I told you, I am going to tell you something the major problems that can happen to the eyes because of fall of chemicals. All of you be knowing now the chemicals are divided into acids and alkalis, which are normally used in our household activity, household areas also. They are using chemicals to clean everything. That is what is called the chemicals when it accidentally falls into the eye, unless they are treated promptly, they can produce complications. If you see that, the eyeball cut sections, you can see here this white structure. Can you see this? These are the white structures. These are the white areas. And this red. Here is the extreme part called ora serrata. That is a part of the retina. Now we got this entire area is called as ciliary body. The ciliary body is supposed to be called as a dangerous area of the eye. Dangerous area of the eye. This one important point they can ask you in exams. Okay. Next we have got same thing now. This called, you can see a construction has been made. These white structures are all ciliary bodies. And you can see an intraocular lens also inside. That means the patient had intraocular lens also. This was just to show you the ciliary body is very dangerous areas. I want to show you, and this also they can ask you, this view of taking photographs is called as Apple Miyake view. Apple Miyake. This is called Apple Miyake view. Apple Miyake view. Now I told you there are so many chemicals which can affect your eye, maybe acid or alkalis. One important point I want to stress the important point is when the acid falls in the eye, immediate coagulation of proteins, thereby further penetration is prevented. Further penetration is prevented. That means late complications may not happen, but doesn't mean acid is good. It can produce problems for the patient, but it can further, after some few years, the complications they're going to occur. May not occur in the case of acids, because acids produce precipitation or coagulation of the proteins, thereby further penetration is prevented. Whereas in the case of alkali, when it falls, like when I got ammonium compounds, sodium hydroxide, calcium hydroxide, calcium oxide, so many things are there. These chemicals, when they fall, they combine. These chemicals combine with your fats. They combine with your fat. That is called saponification. That process is called saponification. That is, fats or combined with the chemicals remain there for some time. They have to be there. They remain with the fats. Now what happen now? In future, these chemicals which are attached or with the fatty tissues, they can come out and enter into deeper areas of the eye, produce late complications. This is what you're supposed to know. That's why when you compare acid and alkalis, it is said alkali is more dangerous. Acid is comparatively less, but doesn't mean both are dangerous only. Don't forget about that. But compared to acids, alkalis are more dangerous because they can produce late complications. For example, I'll show you here. You know the acid substances. We have got sulfuric acid. So many acids are there. But the most important point you're supposed to know here is the acid, the hydrofluoric acid. They can dissolve the tissues. They can penetrate easily. The problem, the hydrofluoric acid, they can dissolve the tissues. They can easily penetrate in this case also. But the problem is what? A minimum of 2.5% of burns. 2.5% of burns that can happen to hydrofluoric acid may be lethal, may do more damage or may kill the patient also. That's what the important point of hydrofluoric acid. It's also a viva question. Now, I told you about the alkali. Alkali, most important, I told you what now, it combines with the fat, remain there for some more time, and later on penetrate deeper areas, and can produce complications. You see here one thing called lye burns. This lye burns. Lye is what? Sodium hydroxide. Lye is otherwise called sodium hydroxide burns. What will happen now? This chemical will remain in the fat. Later on, they can enter inside, and what by now they can produce a problem like this. This is called retinal dialysis. Retinal dialysis. Retinal dialysis. That means, what do you mean by that? The retina has developed a retinal tear near the ora serrata, that is the peripheral portion, ora serrata of retina. That is called retinal dialysis. Can occur in a patient who has been exposed to sodium hydroxide burns. I told you that's called lye burns, sodium hydroxide burns. Now, when you know one important point, when the patient has come to you with a history of chemical injury, any chemical for that matter, said a bleaching powder has fallen, calcium oxide, or this chuna has fallen. Don't ask any other questions. You know, patient had a history of chemical injury. Start treatment. Start. What is a treatment, man? Just clean, wash with a plain water. It's enough. Plain water is enough. If you got a facility, if you're in a hospital, yes, you can apply a drip set with a saline drip, and you can continuously irrigate the eye. That is different. But when you don't have that facility, better options. So plain water, but clean water, not contaminated water. You must use a plain water to wash. You know the reason here? I want to remove the maximum chemicals from the tissues. You should not leave any remnant of chemical in the conjunctival area, in the conjunctiva, or any other area for that matter. If you take conjunctiva, classically, the upper fornix area is more common. So naturally, you have to search for that also. That's why you are washing what for? To remove the chemicals, maximum chemical that may remain inside the eye, in the eye, to remove. That's all. This is the most important activity of your cleaning or washing. That's why I'm telling you now, classical statement. Chemical injuries, you know one thing, it's a only emergency in whole medical field, wherein you can start the treatment with history alone. No need to examine. First, don't examine. Don't waste your time in examining the eyes and all. First answer is wash. Not only 3-4 minutes and all. You must continuously irrigate at least for 40 to 50 minutes. Then only can be sure that all the chemicals might have been removed from the surface. That's why washing at least for 40 minutes. Once I have done that, I am going to examine the person now. I am going to examine the person. That only I am going to examine. History, of course, okay, yes, told you what? Chemical. But don't ask history like this. Where chemical, how many hours, something, no need. Just know that wash. That's all. That's the most important point. Classical exam question. You have to first cleaning. Then you apply. You can start examining the person. The examination, what now? You have to record the visual acuity. That's the most important point. But when you see that, when you are examining the eye, you can assess the prognosis. What happened if the patient is treated or whatever thing is there? What happened to the patient in future? That means you have to assess the chemical injury. That is called grading. How do you go to this assessment? What are you going to do with this assessment now? What are you going to examine now? Just see around the limbus, ischemia is there. Normally, you know, up the limbus you can have vessels. You know that. So naturally, around the limbus, vessels are there not? That is called ischemia, limbal ischemia. Then see the cornea. Cornea is clear or not? When the cornea is clear, you can see the underlying details, the iris, pupil and all you can see. Or the cornea is opaque, you cannot see. Similarly, extent of conjunctiva involvement. What's the percentage of conjunctiva is invaded or involved? Not invaded, involved. That's called conjunctival involvement. These three things you have to see. When you are examining the person after washing, see these 3 points. See the limbal ischemia. See the corneal clarity. See the involvement of conjunctiva. That's enough. I'll tell you how to basically what happens in home. The limbal ischemia is there. You know, you got 360 degrees. You know, we got 360 degrees. I'll show you a picture here. Now you see 360 degrees, you got limbal. See now here, this is what 360 degrees, you have got the limbus is there. No, this limbus. See the surrounding thing is opaque. See the areas are opaque. That means what? 360 degree ischemia is there. You know, normally you can go out a grade now. Ischemia, no ischemia, very good prognosis. No ischemia, very good prognosis. Suppose it is less than 1/4. Okay. If it is less than above 1/4, but less than 100, half is good. If ischemia is more than half circumference, involving more than 180 degrees, very dangerous. That means the cornea will definitely suffer. That is why you see the limbal ischemia, extent of limbal ischemia. It can give us a clue regarding the prognosis of the patient. Similarly, cornea. If you see the cornea, you see here. See the cornea opaque or it's totally clear. What do you mean by that? When the cornea is very clear after chemical injury, you can see the underlying iris details and all. That means prognosis is good. Prognosis is good for the patient. Whereas the cornea is opaque. Nothing is seen inside. Very bad prognosis. That means you cannot save the eye cornea. That's what you are supposed to know. So you are classifying the grading or assessment in the severity based on limbal ischemia. No ischemia, good. More than half ischemia is there, very bad. Similarly, cornea clarity, very clear, good. In between, I got other gradings. So opaque, definitely very bad. Like that you can tell. And conjunctival involvement also you are supposed to know. This is some of the names of the, at least just know for exam purpose. You should know the names of the persons you have classified. The chemical injuries. Never forget Roper Hall and Hughes. Roper Hall and Hughes classifications. Of course, Duas what? He has introduced or he has involved or he has brought your conjunctiva also into picture. Before that, when Roper Hall and Hughes were telling cornea and limbus. Based on that, they told the severity. Just know this is enough. You see the total cornea is opaque. And you see the limbal ischemia is also here. The limbal ischemia is here. Can you see now? That means a very dangerous problem for the fellow. It's a chemical injury is very dangerous. I told you now. One important point in exam again will ask you, which is the chemical when it falls within 5 seconds, you can see within the eye. That is anterior chamber. Your answer should be ammonium compounds. Ammonium compounds, ammonium chloride, ammonium hydroxide, like that. This is the compounds. The ammonium compounds are notorious. When it falls, within 5 seconds, you can see within the eye. That means what? The damage is already over. That's why we have to be very careful about that with the ammonium compounds. So ammonium compounds are very dangerous. Then I told you now here. Now, the patient has come now. Patient has come now. He has given a history of chemical injury. Now I told you, you have to wash with the plain water, or if facility is that I can put a drip, continuous irrigation on the eye, can pass a normal saline. But don't think like that. No, when acid is fallen, you can use alkali to neutralize. If alkali is fallen, don't tell acid to neutralize. Very dangerous practice. Don't do that. It will produce more complications for the fellow. More complications will be produced to the patient. Now, when you assess, already assessed about the gradings, and I have told you, now we are going to, I already told you, the only emergency in whole medical field where you can start the treatment history alone. Now, what are treatment modalities? See, when a chemical is fallen, I will tell you what happens to the eye. When a chemical is fallen, there are some bulbar conjunctiva, palpable conjunctiva. These are all the superficial areas or layers. They can get damaged. The raw surface can be produced. When the raw surface, palpebral and bulbar, that's all. Palpebral and bulbar part is close by. When a raw surface, they can attach, they can remove what is what? It's called symblepharon formation, symblepharon formations in future. And see now here, the chemical is here in the fornix. The chemical is here in the fornix. That's why when you have a chemical injury, you have already assessed, you are going to start the treatment modality. I've already started the cleaning area. Now I should what? Apart from washing, I will do what is called, again, an exam question. I have to do double eversion. This called, I have to double eversion means one eversion in the upper lid, one more eversion in the same lid. Of course, I have to use some instruments. That is called double eversion. What for? To see the chemicals maybe here. That means you have to remove these chemicals. Otherwise, it will remain there for some more time, create complications for the patient. That is why your answer is double eversion. That's why I've given a roll of double eversion. Roll of double eversion. Okay. Now I told raw surface. Raw surface is there. And palpebral conjunctiva, bulbar conjunctiva can get attached to this symblepharon. That means low roll of glass rodding. What do you mean by glass rodding? You take a glass rod, even a thermometer is enough. Thermometer is enough. You just smear that with an ointment. Smear that with an ointment. You just pass between the eyelids, between the eyelid and the eyeball. Just pass it daily. You can apply, and you can even apply ointment also, antibiotic ointments, which can prevent, of course, secondary infections also. That's why first washing, next examine the person, next what? Double eversion, and remove the chemicals if they are in the fornix. Number 3 is what now? We have to do glass rodding. What for? To prevent late complication like symblepharon adhesions. Now for healing purpose, I have to give massive dose of vitamin C. I have to give even 2 grams per day. 2 grams per day to be given orally so that it can help in healing process. That is called systemic vitamin C in massive dose. If an ascorbic acid is available as a drop, that also can be tried, but it's not possible to get easily. Whereas when the chemical has fallen, I told you, now we have got the conjunctiva has got goblet cells. Goblet cells, conjunctiva has got goblets, G-O-B-L-E-T, goblet cells, goblet cells. These goblet cells are what now in the conjunctiva? They produce mucin. This mucin is a must for holding the tear fluid intact. Otherwise, tear fluid will break, which can result in dryness, dry eye. That's why a chemical has fallen. Definitely the conjunctiva goblet cells would have been destroyed. So naturally, that patient requires, any chemical injury patient, you have to give artificial tears. That is called roll of artificial tears. You can have sodium, you got so many things, cellulose, sodium cellulose, so many things there, methyl cellulose and all. So methyl cellulose you can use, or sodium hyaluronate you can use. That means what? Artificial tears have to be used. In the management of any chemical injury, you have to use artificial tears also. One more important point. When the chemical has fallen, you know cornea is made up of collagen fibers, collagen. Sclera also made up of collagen. Now, what happened now? Chemical has fallen. The shrinkage, the collagen fibers shortens. The fibers, shrinkage of collagen fibers, shrinkage. They shrink. When they shrink, you know what happens now? The collagen is shrinking. The skeletal collagen is also shrinking. That means what? In the anterior chamber, near the angle, when they shrink in the angle of the anterior chamber, naturally the aqueous humor cannot go out, resulting in raised intraocular pressure. That means it's going to end up in glaucoma also. That is why in all chemical injuries, better be careful. You have to apply anti-glaucoma drugs, like maybe timolol, maybe bitoxolol. So many things are there. So many drugs are available for us. So we can use those drugs to reduce the intraocular pressure. Never forget this. So chemical injury patient, we have to use. One more point I'll tell you. Chemical has fallen. You know, we have got cornea has got collagen Stroma has got collagen type number 6. Decimate membrane is there, collagen type of 7 and 8. That means collagen is there. Collagen makes your cornea, main structures. Now the collagenase, there's an enzyme. When a chemical has fallen, can come out of the epithelial cells damaged, or even inflammatory cells can come there, and they can liberate collagenase. This collagenase can come out and destroy your collagen of the cornea, so the cornea gets thinned out, and they can perforate also. That is why chemical injury patient should get collagenase inhibitors. Collagenase inhibitors also a must. Never forget this. A common exam questions. Now we'll ask you, doctor, can you tell some collagenase inhibitors? We'll ask you like this. Can you tell some collagen inhibitors? Never forget, use the word tetracyclines. Tetracyclines. Collagenase inhibitor. Tetracyclines can be used. And other things like sodium EDTA, ethylene diamine tetraacetic acid. Sodium EDTA, ethylene, you know what? EDTA. That is what is a chelating agents. Ethylene diamine tetraacetic acid, which can chelate the sodium, so they can remove the calcium. That's one of the chelating agents. Acetyl cysteine and cysteine, they are all directly acting. They can directly inhibit the collagenase. Whereas sodium EDTA, it removes the calcium from the tissue, the corneal tissue. They can remove. That means you should know one thing: the cornea, the collagenase requires calcium for its activities. That means what? When the collagenase is a must in the, it has to work, means it needs calcium. When the calcium is removed by the sodium EDTA, calcium is not there, collagenase cannot work. That means perforation may not take place. Similarly, how the tetracycline is going to help you? Tetracycline, how the drug is going to help you? Your answer is, so tetracycline can remove the zinc. The tetracyclines can be given orally, which can remove zinc from the tissues. Zinc also is a must for the activity of collagenase. Zinc has to be there, then only collagenase can work. When the zinc is not there, collagenase cannot work. That means you can at least prevent the perforation. So the cornea, after chemical injury, you can prevent the perforations by, just know this, collagenase inhibitors. It's a common exam question, collagenase inhibitors. That means when you ask collagenase inhibitors, you must tell, sir, there are some drugs which can directly acting, inhibiting the collagenase, inhibit. They are all what? Acetyl cysteine and cysteine. Acetyl cysteine and cysteine. These are all directly preventing collagenase. Whereas EDTA and tetracyclines, they're all indirectly acting. That means they remove something which is must for the activity of collagenase. They remove that. The problem is solved. This is what the role of collagenase inhibitors. Never forget this. Now I have given role of mydriatics and role of artificial. I already told you about role of artificial tears. Now role of mydriatics. Never forget, when you have a collagen, this chemical injury has occurred, naturally you can expect the chemical would have entered your eye. It would have gone to your eye. That means what? You would have developed uveitis, iriditis, iridocyclitis. These type of inflammations may be there in the patient. To control that, minimum treatment is what? You have to dilate the pupil. You have to dilate the pupil. That means what? Mydriatics. Because what for? And cycloplegics, you know, that's like ciliary body also, it will be muscles also to be paralyzed. You are giving rest to the eye. You are giving rest to the eye. Rest. And also preventing synechial formations, attachment of iris to the lens. You can prevent. These are all the common questions. So you are, in a case of chemical injury, never forget, if you have got evidence of uveitis, you must apply mydriatics. Never forget. Mydriatics or cycloplegics. One example, classical example is atropine. Atropine is a mydriatic and cycloplegic. We can have tropicamide, both cyclopentylate, both activities. Everyone knows that. Homatropine, both activities. Never forget this. That means you are going to give a drug which can act both on iris as well as ciliary body. That's called, actually I have told you, role of cycloplegics and mydriatics. Now I already told you, tetracycline, how that drug acts. That means doxycycline, 100 milligram OD, BD, that is twice a day, chelation of zinc. taking place, thereby the collagenase activity is reduced. Now, there are certain things, iodine, you need, if you have available, you can do, otherwise only plain water, is nothing. Iodine, starch, aniline dye, can you have glycerine is available, glycerine. Aniline dye has fallen, glycerine is very useful. Never forget lime, calcium oxide. Never forget. If EDTA is available, you can apply that. You know why I'm telling you now? When a lime is fallen and you are applying water, what will happen now? Lime is attacking with or joining with the water to create heat. Intense heat is produced. The intense heat can produce more thermal damage. Thermal damage is produced. Heat is producing complications. That means what? I do not want heat to come. It should not give a problem to the patient. That when it's available EDTA, it's available lime, problem is there, ethylene diamine tetroacetic acid is there, you can apply that. If not, you can apply continuous water. Of course, nothing wrong. If only you put a drop of water, it'll produce heat, man. Suppose they put continuously going on water, continuous irrigation is there. Naturally, heat is produced. It can be cooled by the next coming water. It can cool it. That's why continuous irrigation for 40 minutes. That's why I'm telling you now, most important point. The exam question is what they will ask you. Lime problem is there. Will you apply 1 or 2 drops of water? You should know that, sir, heat will produce. You can have heat complications or thermal injury to the eye, thermal injury. To overcome that, if EDTA is available, I can use it, sir. Otherwise, I have to use a continuous irrigation of water so that I can overcome. That's why I've written water for all except lime. But lime also you can use it, nothing wrong. But you have to use a continuous. You must be very careful. Finally, you can apply pneumatic membranes and all available. Okay, you can apply. They can help you in different manner. They can provide the base membrane. That they can also be useful. They are also useful for chemical injury patients. We got sometimes cornea is opaque, but the vision is there for the patient. Vision is there for the patient. That is, vision means what? The retina is functioning, but the cornea is opaque. You cannot see. In that case, keratoplasty, that means corneal transplantation can be done. But the transplantation of cornea is having very poor prognosis because of intense vascularity. So naturally, the corneal transplantation will fail. To overcome that, I can use what is called some processes there. Processes is called wooden tooth, means tooth, keratoplasty. That means they can apply something, a processes into the cornea. This will have a lens. This will have a lens so that they behave like a cornea for the patient. You can see, that's all. That means some patients may require keratoprosthesis. Processes will have some lens. You are going to attach to the cornea. You have to suture. Like that, these are some procedures you should know. Okay. Next, what now? Now, I told you, mydriatics to be applied. Now, I told you, mydriatics, there are so many mydriatics. Mydriatics, what now? Atropine, homatropine, tropicamide, cyclopentylate. You know all these things, the pharmacology of all these things. We got parasympathetic mimetics. Mimetic is what? Pilocarpine, acetylcholine, these are all mimetics. I want to destroy the activity of acetylcholine. I have to stop the activity of acetylcholine. I am going to use what now? Parasympathetic lytics. Lytic. Classical parasympathetic lytic is atropine. They can block the receptors. Now the acetylcholine cannot go and act it there. That means the blockage of the receptors. Okay, that means blocking of the receptors, the parasympathetic mimetic like acetylcholine, they cannot work. Same way, these are all parasympathetic lytics. What I have told, no, atropine, homatropine, cyclopentylate, tropicamide, these are all parasympathetic lytics. But now, these are all what? Acting on sphincter muscle. These are all what? Constrictor muscle of the iris. These are parasympathetics. Whereas the dilator is there. Which has got sympathetic system. Sympathetic is in what? Sympathetic supply is there. That means what? I can dilate the pupil by stimulating the dilator also. I can stimulate the dilator also. That means what? Paralyzing your sphincter muscle by atropine, paralyzing the parasympathetic receptors, like your constrictor pupillae muscle. I can stimulate your dilator also by giving sympathetic mimetics like epinephrine, but never forget. This is a common, tricky question in examinations. That time you'll definitely forget. Never forget, in a chemical injury, you have classified or graded the prognosis based on limbal ischemia. Limbal ischemia, blood vessels constricted. That means blood vessel is not there. When I apply epinephrine or phenylephrine, these are all vasoconstrictors. These are all vasoconstrictors. By chance, imagine one example. I'm having a ischemia of limbal ischemia is there, 1/4, 1/4 ischemia. It's good prognosis. Someone can easily save. But now I apply phenylephrine on the top of it for a mydriatic purpose. Now we can produce remaining 3/4 also vasoconstriction takes place. And the entire 360-degree ischemia is taking place. The cornea suffers. That's why phenylephrine, epinephrine, these are all contraindicated in chemical injuries. Never, never, never. You must always remember this point. They are never used. Suppose I tell you, if you see get a case of chemical injury, if a phenylephrine eye drops is there or something, tropicamyl plus, plus means what they will have epinephrine also, phenylephrine also. So never keep that drug in front of inside near the patient. You do not know, sometimes some nurse will come and put the drugs. That's enough. That's why you must always be very careful. Chemical injury patients never, never, never apply phenylephrine or epinephrine eye drops. These are all contraindicated. Now, steroids. I'm having mydriatics, cycloplegia, I applied for iritis, but normal circumstance, what now? Normally, we apply steroids also for a case of uveitis patients, steroids. But never forget, steroids, eye drops are used. Today, chemical injury is fallen means within first week only you can use. First week steroid, yes, even cornea maybe, epithelial damage may be there, doesn't matter. Doesn't matter, epithelial injury may be there, you can apply steroids now, in this case. That is what? Steroids, first week, yes, what for? To prevent inflammations, to overcome the inflammatory signs. Whereas, second and third week, no steroid, don't apply steroids. Why? Your answer is, they can prevent healing. The reparative process is inhibited. The healing is prevented. Now, fourth week onwards, that is after injury, fourth week onwards, you can apply steroids. Again, what for? Your answer is to prevent complications like simple ephrine. This is the role of steroids and role of mydriatics. Never forget as far as examination is concerned. Steroids, first week, yes, to overcome inflammation. Second and third week, no, because it can produce healing, delayed healing process. Healing is delayed. Whereas fourth week onwards, yes, you can prevent complications. Okay. Now, if you want to have a continuous irrigation, suppose I want to have a continuous irrigation of the thing, we got one lens is available, Margan. We can have a Margan lens, M-O-R-G-A-N, Margan. That is called Margan lens. Margan lens. That is, this is like a contact lens. A lens is there. You can apply drip. They can continuously irrigate. So naturally, I can apply the contact lens on the surface of the cornea. You can irrigate the normal saline. The entire thing, even you can fill for 1 hour, 2 hours, nothing wrong. That means continuous irrigation can occur at the Margan lens. That's also an exam question for you. Do you have any lens which can you can use it for continuous irrigation? Your answer is Margan lens. Your answer is Margan lens. Hope you have understood something about chemical injuries. And never forget, most important point is what? When you get a history of chemical injury, start washing. Cleaning. Then proceed further. This is what my advice. Thank you very much.